Good morning, this is Chad McQueen reporting from ISTH 2015. This morning I have Dr. Alok Khorana from Cleveland Clinic. We're here to talk about the CATCH study. Dr. Khorana, can you tell us a little bit about the CATCH study, what your findings were, and some key pearls?
So the CATCH study is a big randomized trial of 900 patients with cancer who had a blood clot. Now we know from the clot study that was done about over 10 years ago that cancer patients seem to do better with the low molecular weight heparin. But if you look at actual market data, less than half of patients get a low molecular weight heparin for treatment of their blood clots. So we thought maybe we needed a second confirmatory study. And one of the challenges with the clot study was it was primarily a North American study with a couple other countries thrown in. In CATCH, we went global, so this was a global worldwide study. It was bigger, it was 900 patients. It's more in sort of the contemporary era with new systemic therapy agents. And what we found was essentially that low molecular weight heparin was superior. So the drug used in this study was tinzaparin. It had a rate of recurrent VT that was substantially lower, about 35% lower than patients who were on warfarin. The hazard ratio for the primary endpoint barely crossed 1, but it was still statistically significant based on the per protocol analysis. And if you looked at individual components of the endpoint, one being symptomatic DVT that was statistically significantly better with tinzaparin. And then different from the clot study, we also found that bleeding rates were significantly lower in patients receiving tinzaparin for clinically relevant bleeding. So lots of good benefits to cancer patients, lower symptomatic DVT, lower clinically relevant bleeding, and again, overall better composite endpoint with the low molecular weight heparin.
So in cancer patients, why is the balance between appropriate anticoagulation and bleeding so challenging?
So, we commonly perceive of cancer patients as being hypercoagulable, but they're also at risk for bleeding, and people sort of tend to forget that. So the prevalence of bleeding in the cancer population is very high. And so you want to anticoagulate them appropriately, but you also want to be mindful of the adverse effect of major and non-major clinically relevant bleeding. And so you want to balance those two things. So you don't want to give sort of extended treatment to patients who don't really need it, and you don't want to withhold it from patients who really do need it, because thrombotic events are the second leading cause of death in patients with cancer. So finding that balance can be challenging, but it's necessary for our patients.
So you mentioned that the old study with Dr. Lee, with I think you said dalteparin, there wasn't the uptake that you would have liked to see in the patient population. Why is that, and can you think the results from this study can help to change that in the U.S.?
I believe so. So one of the things we're presenting at this ISTH is the analysis of risk factors and biomarkers, and what we're able to find is that there's 4 variables: the levels of tissue factors, C-reactive protein, the type of cancer, and whether there's a mass compressing the venous system. Those 4 factors accounted for 74% of recurrences. So ideally we would want the majority of cancer patients to be on low molecular weight heparin, but if you're not going to put everybody on, at least these 4 factors should be taken into account. Those patients really should be on a low molecular weight heparin, and they should be on it for a long period of time.
So physicians that are watching this show today, what do you want to tell them about a low molecular weight heparin in a cancer patient? When should they be on them? When shouldn't they be on them? What are their take-home points?
So the standard really should be low molecular weight heparin. At the Cleveland Clinic, we started a cancer and thrombosis service, and so all blood clots that are diagnosed at the clinic in cancer patients are taken care of by one person carries a pager, and you just call that pager and we take care of it. And we are able to increase our uptake of low molecular weight heparin from about 50%, which is the national standard, to 80% of our patients are getting treated with low molecular weight heparin. So it's doable. You just need to sort of establish the pathway that does it, and as based on the findings of the clot and the CATCH studies, it's clearly beneficial to patients.
Dr. Khorana, thank you for telling us about the CATCH study. Thank you for coming by and having this interview this morning, and best of luck the rest of the meeting.
Thank you.